Ooh, run, Ralphie! Those bullies are gonna catch you! Quick, over that fence. Ooh, man, too late. They're catching up. Maybe hide behind that old beat-up Jeep and pray they don't find you? If not, I think you're gonna suffer from some, blunt abdominal trauma. Which brings us to the topic at hand, actually. The majority of blunt abdominal trauma is caused by cars, motor vehicle collisions, and auto versus pedestrian cases. Other common etiologies are falls from a height and direct blows, assault, like Ralphie's about to get, or bicycle collisions. Be alert for suspicious stories. While you should trust what your patient is telling you, if something isn't adding up, know that blunt abdominal trauma may be associated with domestic violence or child abuse as well. The abdominal cavity is not protected by bony structures anteriorly. It's soft and mushy in front. In back, however, there's the rigid spine and rib cage, and organs can get squished against these, causing injuries. And we need look no further than this Jeep for the different types of injuries organs can suffer. Hematomas are essentially a big bruise or collection of blood in or on an organ or structure. Solid organs, like the liver, can lacerate and bleed, or broken bones like ribs or pelvic bones can lacerate anything in their path. Hollow viscous structures like the bowel can rupture or perforate, or they can be ripped from their vascular supply, like the mesentery, called avulsion or devascularization. Injury to the vascular system itself or vasculature within an organ can lead to hemorrhage. Caring for these injuries can be challenging, but with an organized approach, the evaluation of a patient after blunt abdominal trauma can be both fast and accurate. Patients can range from being completely asymptomatic to being severely critically ill. As with every single trauma patient you'll ever see, we always start with the ABCDEs of the primary survey, followed by the secondary survey. We covered these in our initial management of a trauma patient sketch. Clinical findings that suggest abdominal injuries should all prompt deeper workup. So, let's go through those now. Ugh, yep, Ralphie's definitely gonna feel that tomorrow. First, the most obvious, abdominal pain and tenderness. Pain is a reported symptom from a patient, whereas tenderness is a finding elicited on exam. At Sketchy, we don't condone bullying, but don't worry, Big Bad Billy Z here is gonna get his comeuppance. Maybe not in this sketch, this one is just to set the scene for the rest of the Sketchy series. Peritoneal signs like rebound tenderness, guarding, and rigidity suggest blood or another substance irritating the sensitive peritoneum, which you can remember by this rock rebounding off the hood. Abdominal distension, like this distended beach ball, may also indicate severe injury, like hemorrhage filling the abdomen with blood causing progressive distension. More severely injured patients may be in shock, manifesting as hypotension, like our passed-out sunbather. Always remember, the most common cause of hypotension in trauma patients is hemorrhage until proven otherwise, which can definitely be from the abdomen. Bruising across the lower abdomen from a seatbelt is called, you guessed it, seatbelt sign. Super inventive, I know! It gives an idea of the forces during the mechanism of trauma, and organs under the seatbelt are at risk, particularly the bowel and bladder, both of which can pop. Ugh. Who cares about splenic rupture? We do! CARE sign is referred pain from splenic injury felt at the left shoulder and neck from blood irritating the peritoneal lining of the diaphragm, just like this arrow is pointing from the torn spleen bottle up to the left shoulder. A similar referred pain from liver injury goes to the right shoulder, but it doesn't have a specific name. Is it Halloween, or is that just your average bullying outfit? Then again, if it's Halloween, what's that guy doing sunbathing? To each their own, I guess. Patients with major distracting injuries, like Femur fractures, symbolized by the torn skeleton outfit, or altered mental status, represented by this cracked brain helmet, require workup for abdominal injuries, as the patient can't or is too distracted to give you a solid clinical exam. Keep in mind that patients may be completely asymptomatic initially, but the absence of these signs and symptoms does not rule out intra-abdominal injury. In fact, certain significant mechanisms alone can be enough to warrant workup for abdominal injuries, even if there are no other signs or symptoms of abdominal injury. This goes for patients at high risk for injuries, like elderly or immunocompromised patients. Okay, so we've got some suspicion of abdominal injury. So how do we actually work up the abdomen? First up is the FAST, which stands for Focused Assessment with Sonography for Trauma, for which we've brought in our recurring symbol, a metal detector. Sure, this one's for beachcombing, but you see the connection. FAST is a bedside ultrasound of the most dependent areas of the pericardial and peritoneal cavities, looking for free fluid, particularly blood. Remembering back to our sketch on the initial assessment of a trauma patient, where we followed the ABCDEs, the FAST exam occurs during the C step for circulation. FAST is indicated for and must be done for patients with hemodynamic instability and signs or suspicion of blunt abdominal trauma based on mechanism. FAST is not required, but is usually still done for stable patients with signs or suspicion of blunt abdominal trauma. However, if the patient is going directly to CT, a case can be made for not performing one. FAST detects free fluid, which in trauma is blood, until proven otherwise. Other fluids that could be there are urine from a ruptured bladder or spilled GI contents from a perforated bowel. Blood and fluids are anechoic, meaning they look black because they don't reflect ultrasound waves back to the transducer. The areas checked are the pericardium, the hepatorenal recess, the splenorenal recess, and the pelvis, shown by these stars on the life vest. First up is the pericardium. For the subxiphoid window, the probe is tucked under the xiphoid process and angled towards the heart to show cross-sections of the chambers of the heart. Blood will pool as an anechoic stripe between the visceral and parietal layers of the pericardium. Next up is the good old hepatorenal recess, also called Morrison's pouch. The probe is positioned on the right flank at the bottom of the ribs and fanned from anterior to posterior, viewing along the way the lower right pleura, the liver, and the right kidney. Blood appears as a thin dark or black stripe between the capsule of the liver and the fatty fascia of the kidney. On the left, the probe is placed on the left flank at the bottom of the ribs to examine the splenorenal recess, spleen, lower left pleura, and the left kidney. Finally, the pelvic region is examined by placing the probe in the suprapubic region just north of the pubic bone. This space is called the rectouterine pouch in patients with a uterus, also called the pouch of Douglas. Otherwise, it's the rectovesical pouch. Fluid tends to collect behind the bladder. Hemothorax can be identified with the right and left flank views. But what about pneumothorax? For this, adding bilateral views between the upper ribs makes it an EFAST for extended fast and checks for the normal sliding of the two edges of pleura together. For a review of pneumothorax and its ultrasound findings, check out our Viking raid sketch. If any fluid is seen on any of these views, it's positive and suggests significant injury. A FAST is negative only if all the spaces are without fluid. A FAST can also be indeterminate if for some reason one of the spaces can't be seen or if there is an inadequate view. FAST has largely replaced another procedure used to detect intraperitoneal hemorrhage called the diagnostic peritoneal lavage, or DPL. FAST is much less invasive, much more portable, and much faster. However, sensitivity can be low, and it cannot distinguish between types of fluid, whereas DPL can. DPL is performed by inserting a needle into the peritoneal cavity and aspirating back. Good, 'cause I definitely prefer a bitty needle than a big honkin' harpoon. If blood comes out, well, you've got your answer. If not, 1 liter of saline is washed into the cavity and aspirated back out. This is the lavage part. Ugh, that got graphic quickly. Anyone else reminded of Jaws? Hang on, wait, that's the wrong 80s movie. A DPL is positive if greater than 10 milliliters of blood on initial aspiration is seen, or if the lavage demonstrates enough red blood cells, white blood cells, elevated fluid amylase, or the presence of bacteria or enteric contents. We'll talk about fast from here on out, but a positive DPL follows the same decision-making algorithm as a positive fast. Okay, decision-making time. We've talked about clinical findings, we've talked about the fast, so now let's apply them. The first question to ask is whether the patient is stable or unstable. We'll start with unstable patients first, then finish up with the next steps for stable patients. A positive fast in an unstable patient? Go straight to the OR. Do not pass go. Do not collect $200. An unstable trauma patient with a positive fast is a strong indication for emergency abdominal exploration. So that's simple enough. But what if the fast was negative, or worse, indeterminate? It doesn't mean you're off the hook yet. They still may need to go straight to the OR, particularly if there are clinical signs of abdominal injury, such as persistent abdominal pain, persistent hypotension, peritonitis, persistent hematemesis, or hemorrhage from an NG tube, or evidence of significant abdominal injury on X-ray, like free air under the diaphragm or a ruptured diaphragm. Note that some of these are findings that would send a patient immediately to the OR for XLAP, regardless whether there was any trauma at all. To finish up the unstable group, an unstable patient that does not have any of these clinical signs and has a negative fast should be aggressively resuscitated concurrently with expeditious workup to find the source of their instability, which could be from other severe non-abdominal injuries. Okay, so let's say we made the decision to take the patient to the OR for an XLAP. The exploratory laparotomy, or XLAP, begins with a large midline incision for access into the abdomen, like this fisherman. The goal is to fix whatever is killing the patient now, and then get out of the OR as fast as possible. Hemorrhage is dealt with first by ligating bleeding vessels or resecting non-essential organs like the spleen. Then, contamination is dealt with by sewing up holes or resecting very damaged areas. Then the patient is closed temporarily and brought immediately to the ICU for continued resuscitation, with a planned take-back in 24 to 48 hours for definitive repair. So that's unstable blunt abdominal patients. What about stable trauma patients? Turns out those clinical indications for an XLAP in an unstable patient also should prompt exploration in a stable patient, regardless of the FAST exam. During this surgery,